So tonight is to gather information about regionalization and to find out how Worcester formed their regional public health alliance. So I'm not going to talk a lot. I'm going to try to gather as much information as possible. A ton of stuff online. 8 communities, or are there more?
6 total.
6 total. So Derek will go into those details. Michael Hirsch is here as well. They can talk about the particulars of the benefits. We have to do a lot of analysis in terms of cost calculation and service delivery. But for those communities that are part of it, I think just Upton. You guys from Sutton?
No, we're from Worcester.
Oh, Worcester. All right, you're with them. All right, so I just have Upton. I thought I was going to get a couple other folks from some other communities. I invited Northborough, Westborough, Upton, Sutton, Northbridge. That was my 4 or 5. Because they're not in the region now, just to provide the forum of them gather data would be, I think, smart thing for us to focus on. So if we can find that economy of scale and that synergy, that's what we're looking for. But today's just really to gather information and ask questions to find out if it would work. I think this is an underpinning for me is to find out if it works for those communities that aren't a part of it, just with us. So not to tread on you guys because we want your information, but if it can work that way too, that's a possibility. But we're open to learn and ask questions about your plan design, because it's been in effect for a couple of years, and the service delivery model that you guys have. So I'll just turn it over to you. I know you have a slideshow.
Sure.
And I'm sure we'll do Q&A afterwards.
Yep, absolutely.
All right. I did a poor introduction, so you might want to cover yourself.
All right. So I'll ask Dr. Hirsch. Dr. Hirsch is the Commissioner of Public Health, and I'm the Director of Public Health. I'm going to ask Dr. Hirsch to lead us off. While he does that, I will hand out some handouts. We hope you all can read and ask questions after that. So by way of introductions, Dr. Hirsch will introduce himself, but my name is Derek Perdizzi. I'm the Director of Public Health. I've been the Director of Public Health since 2007. Been working for the city since 2000, almost 13 years now. As we just discussed, I've been recently appointed to the Public Health Council at the state level. I am also, in my part-time job, a captain in the Air Force for the Air National Guard, doing public health as well. So I'll turn it over to Dr. Hirsch.
Thanks, Derek. So I'm a pediatric surgeon by trade, so that's, I guess, my day job. But Derek and the city manager of Worcester, Mike O'Brien, were in April of 2012. So I'm a fairly recent newcomer to the Department of Public Health, but it's been a very, very busy and transformative time there. So it feels like we've been doing this a lot longer together, but I'm still the rookie, so I lean a lot. Clark and Karen Clark, who are in the audience here, and Derek, who's been a wonderful teacher for me. How I got into the public health realm is working really on injury prevention, because as a pediatric trauma surgeon, I see a lot of the broken bodies that come in after they get into crashes or fall out of windows, or unfortunately are shot, sometimes in our city of Worcester. And I've been working on a number of different angles to try to prevent some of those injuries, and I think that kind of got me involved with the Department of Public Health, even in the days when Jay was involved. So what we've been trying to accomplish, I think, in the last 2 years was the culmination of a 4-year reorganization that happened in the department for unfortunately the very difficult economic times that we had. In 2008, as you know, when the economic crunch occurred across the board, there were some really drastic budget cuts that the city of Worcester had to make, and the Department of Public Health was one of the ones that suffered the most deeply from those cuts. So they went from, at one point, as many as 100 FTEs employed in the early part of 2000 down to only 4 in 2009. So quite a difference. So the city manager decided to commission in 2009 a task force that was really going to look at how can the Department of Public Health rise up from the ashes and reinvent itself as kind of a smart Department of Public Health. We knew that we had a wealth of medical resources in Worcester, a terrific medical school, a new program for public health nursing at Worcester State University, 10 college consortium with many, many different elements within those faculties that had interest in public health. Some very, very cutting edge community health centers that were federally funded. To take all of these players, including third-party payers and some of the think tank kind of people, and put them in a room for about a 6-month period. Mike O'Brien, our city manager in Worcester, had us as a task force sit and think about how we can reinvent the department. So these were the mission and vision statements that we came up with, because really the key elements to this new smart department was that we needed to be a data-driven department. We had to really look at what were the challenges facing us by the statistical analyses we were seeing, both an inpatient setting and an outpatient settings, and then use that to kind of give us a roadmap forward as to what priorities we were going to attack. So that was a charge to essentially do a very involved community health assessment that started in 2010. We also were asked to try to become a regional department. We had great success in mid-2007, 2008. We had started a regional disaster program, which got grant funding from the federal government, and 91 communities in central Massachusetts were collaborating in this emergency preparedness grant, and that really encouraged us that there was economy of scale to be gained if communities adjacent to Worcester would collaborate with us in some of these public health efforts. So regionalization was a big part of what came out of that task force in 2009. And the third, I think, and very important element of what came out of that task force was that we needed to kind of use existing resources and partner in towns, partner in universities, partner in nursing colleges, the Mass College of Pharmacy, right down the line. These were times when reduplicating people's efforts and having 3 and 4 and 5 parts of the city health administration or health care delivery system doing the same thing was really foolish in the setting of this economic crunch. So we came up with this mission to promote the health of central Massachusetts municipalities that joined us in our collaborative effort. And our vision was that we were going to be nationally recognized for this. Our charge from the task force was to try to achieve federal accreditation, which is an involved process, and we are well underway to hopefully doing that by 2015. So as I mentioned, because of the Public Health Task Force's findings, Derek was able to parlay a couple of our local foundations, the Health Foundation of Central Mass, and get us some grant money so that we could hire a facilitation think tank company, Health Resources and Action Company, to help us put together a community health assessment that we could then use as a roadmap to design what are our priority areas for public health moving forward. We also had this district incentive grant that tried to promote us to regionalize, and we started with a dialogue with first with Shrewsbury, and then that expanded to include the townships of Leicester, Holden, West Boylston, and Millbury. And eventually that 6-city consortium solidified over the 2011 into 2012. And we are always looking to expand our reach, because we do feel that if you guys get back to those communities, we're certainly in learning phase of a lot of our relationships, but we think we've been able, from a central location, to be able to provide a lot of the inspectional services, a lot of the support in terms of dealing with health crises that come up, whether it's mosquito issues or weather-related disaster issues. And we try to maintain our collegial and collaborative efforts without really being top-down and demanding that here's what you're going to do. You guys are the local control. We are your facilitators. We are your agents. And I think that's why most of the townships have not really felt like we've come in and kind of usurped any power. It's not any of that kind of play. It's really a collaboration that I think has worked really well. So if a health inspector in town of Boylston is going, West Boylston is going on vacation one week, we now have the flexibility of taking someone from Holden and having coverage for that person. So there's been a lot of that benefit coming from this. So that's kind of how this is set up. We attend local boards of health meetings. We have a central meeting of all of the employees of the different townships coming to Worcester to kind of standardize how we approach inspectional services, how we approach some of the issues that come up in doing response to complaints from tenants or landlords. And we also have the public health nursing services that are based in Worcester, helping us with some of the organization of local flu clinics and other kind of activities in the individual towns. I'll let Derek explain a little bit more about this coming up.
So just before we go to the next slide, as Dr. Hirsch mentioned, we face a major economic crisis, and I would argue that most municipalities continue to struggle with their annual budgets year after year. And so part of our overarching mission is to create a sustainable organization that doesn't require continuing to go year after year after the tax levy dollars. And so I'll talk a little bit about our sustainability plan further down, but as you can see, that's part of our overarching goal, to be sustainable, to be cost effective, and to be efficient in how we do stuff. We'll explain how we organize ourselves to do that work. We are, as Dr. Hirsch pointed out, we have one single organization providing services across 6 different communities. Unlike other shared services agreements where you have, we'll say, a public health nurse in one community and a food inspector in another community, both communities get together and say, we'll share resources. We're not organized like that. We're organized much like what you would envision a county health department to be organized in the southern states or the western states. And each community signs an agreement with the city of Worcester, an intermunicipal agreement. It's just at this point, it's just one agreement with those 2 communities. And so in Worcester's case, we have 5 different agreements. All the same, mirrored the same way, but we don't have one overarching agreement that all communities sign. It's 5 different agreements. So here are some of the goals that we're working on currently. So as Dr. Hirsch pointed out, we have a goal of being an accredited health department. So those of you in the healthcare industry, you understand our hospitals have to be accredited through JACO. Well, there's a voluntary accreditation process in public health, and it's through the Public Health Accreditation Board. It was a goal set forth in 2010 task force report, and we are pressing that 2015 mark. We will be, I can almost 100% say this, we will be the first health department in the state who has been accredited. We are clearly going to be the first health department in the state that even submits its application. We plan on submitting our application November 1st of this year. As Dr. Hirsch pointed out, one thing that we learned through going through this is that we have 5 different communities providing public health services 5 different ways. Some of it good, some of it can be improved upon. So we are working in each community directly with their boards of health, trying to get a better sense of what's important to that community and allowing the boards of health to tell us what's important so that we can standardize how we do business. So it's So when you go as a business owner, if you go from community to community, you'll get the same level of service no matter which community you go, as long as you're working within the health lines. And so that is funded by a Robert Wood Johnson grant. Much like the district incentive grant, we received, our health district received a national award a year and a half ago through Robert Wood Johnson. We were one of 16 health districts in the nation that was selected to be part of a national learning collaborative. And Robert Wood Johnson is just another opportunity for us to continue to refine our processes. And the last one we're going to spend a lot of time talking about is, now, how are we going to improve the health status of our region? And I'll talk just briefly right now about it, but we've been so focused on state mandated functions of public health, which is what most communities do, and they have to do because it's mandated, although it's funded or non-funded, it doesn't really matter. But what we often forget is public health provides a broad array of services, and we typically don't have the resources in the public health department to focus on improving the community's health. We know that we compete on an annual basis with public safety, education, and public works, so at the end, public health is usually on the lower tier of organizations that get funded. So I'm going to talk to you a little bit about how we've been able to cobble that together so that we can focus on health improvement. So I remember the first time we engaged the towns in Central Mass, we had some folks from Cambridge come in, and they presented this wheel to the town managers in that room. And Dan Magato from town of Shrewsbury, he was very impressed with this wheel because this is the 10 essential services of public health. From a local public health department, this is what your department should be doing. Now, most of them in Massachusetts don't do this because we have home rule. We have 351 communities. We have 351 fire chiefs, 351 police chiefs. We have 351 boards of health. So the money gets spread out trying to meet all of our state mandates. And so oftentimes local health departments can't achieve the 10 essential services of public health, although that is what they've been, that is their obligation. Typically, in most communities, they're usually focusing somewhere around diagnosing and investigating public health problems and enforcing laws. To a small degree, maybe the development policies work on their boards of health, like tobacco, like amending the tobacco control regulations. In smaller communities, mobilizing community partnerships can be very difficult. Sometimes there aren't community partnerships, unlike in Worcester. Information exchange is very difficult at the local level because, again, limited resources. Evaluation is non-existent. Will never happen. In fact, even in Worcester, we work with the medical school to do our evaluation for us. So link to providers and create clinical linkages with community-based organizations and clinical providers is something that we're starting to do. So overarching all that is what we should be doing, is assessing on an ongoing basis, creating policies, and then providing assurance to those policies. So from a population health level, we know for an absolute fact that although they're great to do the blood pressure screenings at the senior center once a year, that's great for the 20 individuals who go and get their blood pressures checked, but what about the other 17,000 people that live in the town? So what we try to focus on is what policies can we work with the boards of health, like amending tobacco control policies, that have a greater impact on the population as a whole versus health fairs. So again, the Robert Wood Johnson grant, these are some of the things that we've been, actually we wrote this. So when we got the award, they said, what do you want to do? How are you going to create this cost-effective, labor-efficient health district? And we said, well, this is what we think we need to do. We want to do an assessment of our revenue sources. Again, if we're going to be sustainable, we need to look across all of our revenue sources. We have to look at our grants. We have to look at what philanthropic foundations are out there that can support us. We have to look at what the tax levy is able to contribute. And then our fee structure. Asking the question, is our fee structure actually reimbursing the town for the work that they're doing? And so we're in the process of looking at that across all the different communities. We're looking at fee structures, and we're looking at the cost to deliver those services. So for example, how long does it take to do a food inspection? Not just the inspection, the administrative time pre and post the inspection, and the follow-up work that is required. And then multiplying that by the number of food establishments per the food code to give you a cost. And doing that for each state mandated requirement. So we're working on that. We hope to have that complete by next spring. We're pursuing a number of different resources, grant resources. I was just talking to Jay a few minutes ago. The Prevention and Wellness Trust Fund just came out about a month ago. It's due November 1st. It's a $2 million grant award. I have every expectation that we'll be one of 6 recipients throughout the state to get that $2 million grant. It's focused on prevention and wellness. It's not going to help us fund our food inspection program, but it's going to allow us to get engaged in the community, look at those populations that have high burdens of disease and those populations that are highest risk. The other piece I just want to mention before I move on is one thing that we're heavily invested in is workforce development. Now, there's a pro and con to that. When somebody was just talking, when you train somebody so well, where do they go? They go off to the next community because you trained them so well. So we've already seen that happen, but we spend a lot of our time and a lot of our resources on training our people to make sure that we have the best and the brightest all the time out there doing the work. So this is just a small list of what, for those of you that don't know, a small list of what you're required to do. You as a community are required to do under statute. Control communicable diseases. We have, I don't want to get into staffing just yet, but you're required by statute to investigate all diseases that are reported to the local Board of Health. Enforce sanitary codes like housing, like pools, like camps. We are required to enforce those. Enforce Title V codes, solid waste, hazardous waste, food service establishments. Those are all the things you're required to do. And again, I would argue that all towns do that. I mean, they're required to do it, and they do a very good job of doing that. So this is something we continue to offer as part of the Alliance. And I'm going to turn over to Dr. Hirsch next to talk about the other pieces that most communities aren't able to get to that we're also able to bring to the table as part of providing a comprehensive array of services. So I guess I would say, before I turn to Dr. Hirsch, is that the relationships we've had with the other communities is, this is your health district, and we're going to try to meet all the 10 essential services, given the resources that we have, and we want to improve. We don't want to just do inspections. We don't want to be known as the Alliance that just does inspections. We want to be known as the Alliance that improves population health. So we're going to do the inspections, we're going to ensure safe and sanitary conditions. At the same time, we're going to look at those issues that are highest concern and try to put interventions and measures in place so that we can lower those over the course of time. And it's a great opportunity. Affordable Care Act is asking us to do this already.
I think Derek brings up a really great point, is that I think we're really at a paradigm shift time in medicine where the realities of the bankruptcy, imminent bankruptcy of medical services in this former mode that we were, where we got paid for every little procedure that we did. That's what they call fee for service, right? So now the shift is going to be population-based health improvement. So a town, a region, a medical system, an Affordable Care Act kind of accountable care organization will get a chunk of money. And this is the money you're going to get for your population of patients, and you have this money, that's all you're going to get, so you have to take care of all your population with this chunk of money. If that works, then every time somebody gets sick with something preventable, you're taking money out of that pot and it's pretty much pissing it away. It's a waste. So what we're finding is that now the healthcare providers and the third-party payers are starting to understand that the preventability of so many of the things that get patients into the hospital, into the emergency rooms, into their doctor's offices, makes public health make a lot more sense if it promotes wellness. And that's what the community health assessment, the CHA abbreviation you see there, was really about. It was looking at mortality in the Worcester area, and my predecessor in the commissioner's office, Dr. McGee, came out with a Healthy Worcester 2011 report that looked at premature mortality in the Worcester area. We also had a Common Pathways group, which was a local community health needs assessment organization. They looked at a big report about morbidity, what was getting patients into the emergency room, into the hospital as inpatients, not necessarily killing them. And then we also did, with the help of 9 contiguous school districts, an extensive youth health survey to look at what were the challenges that our youth were seeing as obstacles to having good health. When we got all that data together, we looked also at the state data that was provided by the Mass Department of Public Health, and all of that together we decided was great as a baseline for us to make a community health assessment. But what we also needed was to feed that information back to the communities and get their qualitative input on it, because it wasn't right to have kind of a top-down thing where we're saying to the public, these are your problems. So we started in the traditional way. We had some town hall kind of meetings. We called for different parts of the community in churches and in other venues to come together, and we would present dog and pony kind of slideshows like these to show all of the stats that we were finding about obesity and diabetes and high blood pressure and stroke and cardiac disease and injury and homicide, suicide information. But unfortunately, that kind of way of communicating was kind of going a little bit the way of the dodo. We wouldn't really see a lot of some of the at-risk populations come to these kind of town hall venues. So we flipped it over a little bit. We always have a great gaggle of interns every summer that come from the various colleges and graduate programs that want to do community service projects at the Department of Public Health, and we utilize those folks to set up some focus groups for us, and we invited teens, and we invited seniors, we invited immigrants, and we invited undocumented aliens, and we invited a lot of different segments of the population to come and give us their input. Additionally, as you probably know, I mean, almost every town, I know Grafton has an excellent one, has a kind of a community day in the summer, and every single one of those events, we had an intern at a booth that would drive the folks that came to those events. We would have people driving them to this booth, and we would kind of present them with a little mini presentation, and they would give us some input about what were their health challenges. And then we went really high-tech, and we put a Survey Monkey on the Worcester website for the Department of Public Health, and we had about 1,600 people respond that way to health challenges. So in all, we got a lot of input. We had almost 2,300 respondents in lots of different ways to the community health statistical data. And from that data, we then gathered together in 2 meetings at the Mass College of Pharmacy in October and November of 2012 and came up with what we call the CHIP. The CHIP is known as the Community Health Improvement Plan. And it's based on all of the qualitative, all of the quantitative input we got, and all of those stakeholders that came to that Mass College of Pharmacy Summit came up with these areas, which I can summarize better. It's a huge slide, but we came up with 5 different, we call them domains. And one of them was, as you might expect, healthy eating and active living was a huge component of health challenge for the populace. Behavioral health became part of the domain 2. That was kind of subdivided. Behavioral health was mental wellness, but also the scourge of substance and tobacco abuse. Then we came up with domain number 3, which was access to primary care. But we also threw in that domain the problems that in particular we had in the Worcester area, which was oral health was a huge problem, sexual health was a big problem, and infant mortality was a big problem. So that's all compiled into domain 3. Domain 4 started out as being a violence prevention domain, but when we really crunched the numbers, we're very fortunate that in central Massachusetts, the actual rate of penetrating trauma is very, very low. The perception about it is not so low. That's a very bad disconnect between what the community actually feels about themselves and what the numbers show us. But we were able to kind of expand that domain into including injury prevention, not just violence prevention. So there is a heavy emphasis in this about bullying and gang violence and gun violence and domestic violence, child abuse. But the two real bad actors that are causing most of our injury problems in the area are falls, particularly in the elderly, and motor vehicle crashes. So that is really a big part of Domain 4. And Domain 5 is an interesting one. We, as I mentioned before, we had this think tank from Cambridge helping us to facilitate this whole process, because this was really difficult. With 90 different organizations, it is really the ultimate herding of cats to get everybody together and try to come up with a plan. So every one of these domains, we saw the real problem here in many instances was racially based health disparities. If you didn't have access to a good place to live, you probably didn't have access to a good place to eat. You didn't have access to a safe place to play. So right down the line, we found in every single one of these domains that was a big issue. But we were the first community that Health Resources in Action from Cambridge had done this in, and they've done it in about 30 other communities across the country, bigger, smaller, Detroit, Tampa, Boulder, San Antonio. We were the first place that asked them to make Domain 5 a standalone. And I think a lot of that is to Derek's credit, because earlier, before this whole process even started, he had started an End Racism program that was based at the Department of Public Health that was looking at health disparities. So we were a community already primed to look at this as a major obstacle to wellness. The overarching plan with all of this is we want to become the healthiest health district in New England by 2020. So that gives us 7 years to do a lot of work. Each one of these domains now has a convener leading it, and each one of those conveners has a task force and sometimes 2 or 3 task forces within that domain that are working simultaneously. And here's just to relate it back a little bit to the townships. I'm sure as we're going through these descriptions, you're saying to yourself, is this really something that Grafton is experiencing? You know, I know that you probably don't think of Grafton as a big knife and gun club area where you're getting lots of gunshot wounds, and you're probably not thinking about people in Grafton not having access to good food or options for healthy eating. But what I can tell you is in Domain 2, for example, where we're seeing healthy athletes in the local high school who end up addicted to opioids because they're trying to get through their junior year when all the scouts are coming to get them into Division I schools without showing that they have this bum knee. And they get a little hooked on this stuff, and sooner or later they're raiding grandma's medicine chest to get it, and sometimes they're going into Worcester and trying to get it off the street. These little Vicodin pills that you've heard of are now selling for about $90 a pill in the city. But you can buy a bag of heroin for only $13. And that equation the kids know how to do. And it doesn't matter where they're from, but we can tell you how many people we've found overdosed on the streets of Worcester that are coming from our towns, not from Worcester itself. So I think what this is just trying to demonstrate is that we all have skin in this public health game. And it's silly to think that, you know, if birds can fly without seeing any borders between Grafton and Millbury and all the other towns around, that, you know, that they are real borders here. They're not. These health issues affect everybody. So that's really what we're trying to make real about our coalition. The towns, I think, are benefiting from a lot of the wellness issues that we're bringing up. We have had some very, very great injury prevention sessions in all of the towns. We've had some really good tobacco cessation programs going in all the towns. So I'm hoping that, you know, you'll see some of the value of these programs as they move forward. And we're moving very rapidly. So I'm going to turn it back over to Derek.
So I know we're pushing up against the clock, so I'll just go through some of this. So this is our table of organization. And again, when we enter into an agreement with the town, the agreement is for this table of organization. So it's not that one individual that you're used to having, but you purchase the services of, this is our regional environmental response team. Kerry Cox, that he represents, he's the chief of that team. They are, in essence, in the general terms, they are the individuals that are out there doing the inspections on a daily basis. So our state mandated stuff, the group I talked to you about. Seth Peters is in the back there. He's our chief of epidemiology. We never had an epidemiologist in the past until about 2 years ago. Very critical to a health department if you're really going to be data-driven and paying attention to some of the things that are emerging in the community. Under him is our nursing team and our healthcare preparedness team. And then Karen Johnson's over here. She's the chief of community health. So everything that Dr. Hirsch just talked about in the last slide is all her responsibility. And so she has a few folks under her that are out there in the region and ensuring that all the different health and wellness programs that we have grants for, so we have resources behind this, are being implemented not just in the city but throughout the regions where we find it appropriate. And then at the top, we have a regional public health governance group. So as we consider other communities that want to venture down this path, this isn't our decision. This is a decision that we would bring back to the regional governing group. It's made up of one town administrator from each community, and it's made up of one board of health member from each community. And so when a community wants to think about or wants to propose entering into this health alliance, they need to go before this governance group to ask for permission. So it's not our decision, it's the governance group's decision. So that's very important. And then the boards of health are really the overarching guidance behind all this, because we take our cues from each board of health. It's a lot, I'll be honest with you, we spend a lot of time at night meetings. The town of Millbury, the board of health meets twice a month. The town of West Boylston, twice a month. Shrewsbury, once a month. Leicester, once a month, and Holden, once a month. That's a lot of board of health members that we're always having staff on those to hear the concerns of the board of health and take direction directly from them. So this is our organization from a program perspective. I won't get into all of it, but you can see very quickly we have an inspectional services program. We have funding from the Centers for Disease Control Emergency Preparedness Program, our infectious disease and surveillance program, which is our nurses, who also run all of our flu clinics during the flu season, which is starting soon. Our healthcare preparedness team, all of our substance abuse, which we have grants on underage drinking, prescription drug use, opioid abuse, and tobacco control. And then we have a healthy eating and active living program called Mass in Motion. So you can sort of take a look at, from a program level, all the different things that are happening and that are being offered to the currently 5 participating communities. So from a monetary standpoint, this is what our operating budget looks like. So this is all about grants. So a little less than 50% of the department's operations are built upon grants. So a lot of the health and wellness stuff we talked about, we really want to diversify, this was about the sustainability piece, diversify our portfolio to ensure that we're not reliant on one source of funding, especially during a poor economy when everything goes away. And these are the contributions by the different towns. Obviously the city of Worcester contributing the most, and you can see the large towns contributing more to the operating budget. So this is just taking a look at just the overall contributions from all the different grants. And it's just kind of, we have $62,000 grants, $100,000 grants, upwards of $550,000 grant. And like I said earlier, we are going after a $2 million grant around prevention and wellness, which we feel very confident in landing. So again, I'm not going to spend too much time on accreditation other than what I already mentioned. One, it's voluntary accreditation. We plan on being accredited by 2015. and we have 2/3 of the prereqs already done. The charter and chip are 2/3 of the prereqs. We're building our strategic plan right now. We spent an entire, doing an analysis with the governance group last night in Holden. They are helping us build our strategic plan for the next 5 years for the district as a whole. Once that is complete, we'll have completed our prerequisites, and then we'll enter into the accreditation process, I would imagine on January 1st, and it takes 12 months to go through the accreditation process, which will lead us up to our 2015 now. So just some of the benefits, I hope I don't have to explain this, but increased access to resources, all the grants, all the prevention and wellness money that we continue to seek and go after, expands your reaches as a community into the neighborhoods, into the schools that you all want to serve, expanded services, enhanced capacity. I think a lot of towns have really benefited from that. Those singular health agents in the communities, now when that person goes on vacation, there's backup. Others can cover that, can provide that 24/7 coverage after hours. If there's an emergency issue in the community, I'll give you a great example. I wish they were here right now. The town of Millbury, unfortunately, had a death in their community 2 years ago, and using our staff, we have a public relations team that helps support us. We were able to help investigate the cause of that death with our nursing staff and respond to the media inquiries, the families, and others who had known this individual. Took an intensive amount of resources to handle this issue, given the publicity around it. But speaking for the Board of Health, because they said this publicly at a meeting, that they don't think that they could have handled that without the Alliance as a whole because of what had happened. Holden had a very similar issue the year before when they weren't with the Alliance, and it was handled much differently. So again, I think the other big thing that we offer is bringing our community, mobilizing our community partners in the city of Worcester. So the medical school, Clark University, I could go on for 45 minutes about all the different things that they're doing on our behalf. And we know that with 18 FTEs and everything I just described, we can't do that alone. And so we truly do rely on our community partners. And the towns have benefited from those community partners because that allows us to do the other work that we wouldn't be able to get to otherwise. So I'll stop there because we went on 20 minutes longer than we thought we were going to go on, and just open it up to questions.
What's the cost based on?
So the original cost that we came up with, and so when we went through the original plan with these communities, it was very, because we were going through a planning period, so it was very difficult to say, to do the full analysis that we're doing now. So the cost, the formula we came up with was based upon 3 different factors. One, a 0.5 FTE, so the cost of a 0.5 FTE in every community. That was one factor. The other factor was a $1 per capita basis. That was factor number 2. And the third factor was doing a multiplier, looking at the number of inspections and multiplying that cost, I think it was by like $22 an hour. So we added those 3 factors up, and that's how we derived our original cost. And the towns have continued to pay that original cost until we get to the financial analysis, which may change that cost. But part of doing that financial analysis isn't just saying, oh, by the way, we have a new cost for you, but it's more or less saying, here's the cost that it takes to deliver these types of services. Here are the grants that are going to offset some of those costs, and here is your fee structure. You may not be reimbursed 100% of the cost of providing those state mandated functions, and offering a recommendation to the Board of Health to consider looking at the fee structure. So we don't want to just give information, we want to try to provide recommendations and opportunities to overcome some obstacles, if we even have obstacles, which we don't know yet.
So was there trepidation from those particular communities that maybe their costs were $100 grand and they took in 120 in revenue in terms of their fee structure, and they felt that they would somehow part with that additional 20 if they were to join, you know what I mean?
Well, there's no town that can ever fully recover their true costs because there's a lot of state mandated functions that don't recover any fees. Like for example, housing inspections, there's no fee associated with that. You're required to do that by statute. Unlike food inspection, where you have a restaurant owner, you can charge them a fee based upon the time it takes to do that work.
But that's a sunk cost though for us, right? I mean, if I have a health agent, they have 20 or 30 hours a week. Well, they do a housing complaint or a restaurant complaint, it's still a sunk cost. So I don't know how we're gonna pay for it, we'll never recover the cost.
Right, you're never gonna recover all 100% of your costs to do your mandated functions. You can't, because there's not a mechanism to recover all those costs.
Did communities really break that out for you? Did you see that? You know?
We looked at all of the revenues generated by all the towns.
Okay.
And so, looking at the revenues that are generated and looking at how much they were already paying into the system, we were able to lower their costs by joining this structure. So, let me give you a good example. So one community, for example, they were paying $55,000 for their health agent. They were paying, which is always the misnomer. People always forget about benefits because it's the hidden sheet on the budget book somewhere. But let's consider that. So you get $55,000 salary, you have at least $15,000 in benefits, assuming they're taking health insurance. So now you have a $70,000 line item for your personnel. And then these towns, the one I'm thinking of, is paying almost $15,000 to have a part-time health agent. So now we're up to $85,000, not to include what they were paying to have another septic engineer to cover the person when this person wasn't in. So they were probably hovering around $85,000, $90,000. The first year we entered into agreement with that town, they paid $60,000. And they got all the same services. The only thing they didn't get, and this is what I would caution anybody, is they didn't have the person sitting at the desk waiting for the red bat phone to ring, which some towns like that. They like to see the person sitting there waiting for something to happen. But the fact of the matter is, the work of public health doesn't happen in the office. The work of public health happens out in the field. And so if towns are accustomed to seeing that person waiting for the red bat phone to ring, that's not a way to be cost efficient and labor efficient and cost effective.
Yeah, so do these towns all give up their individual employees?
So yes, and we took every one of them on, 100% of them on as our employees.
So is that something you foresee happening in the future? If you added any?
If we were to work with a town that had one pre-existing employee, which is typically they have one health agent, we could definitely continue to continue to move that.
And do you have a regular presence in any of the communities, or you're there when you need to be and not when you're not?
Well, we strive to have regular set hours and set days where we ensure that people know. So, for example, we have one. Now, this is just for the inspector level. That doesn't include everybody, the nurses and everybody else I just talked about on the TL. For Millbury and Leicester, for example, they share one inspector. So that person does inspections on Mondays and Wednesdays, is available by BlackBerry on Tuesdays and Thursdays, and then is in the opposite town Tuesdays and Thursdays. And so, but they like that because they know that if an engineer comes in and says, I need to speak to, her name's Julie, they say, okay, she'll be back tomorrow morning. If it's an emergency, we can reach her. Or if it's an emergency, we have 4 other people that are in the region that can answer your question.
I'm just wondering from the town's perspective, losing Mary, at the desk who can, set up an inspection or sell trash bags or
right.
Whatever it is, how that gets.
So the most critical person to make this work, and I've said this 100 times, I said it last night, is the clerical staff. Because they're the ones that answer the phones and the call takers. And if they can't handle that, and quite frankly, I haven't seen any that can't, then if they can't, then it would fail. But if you have an open person who is willing to be that person to handle the phone calls and just be a referral agent, then it'll work seamlessly. And it does. And Millbury is a great example. And I'll speak for Millbury because I was a moonlighter before we regionalized in Millbury. And that's how we operated. The clerk would answer the phone, take the complaint, would email me a complaint, I go out and do the inspection, I write the order, I send it to her, she put a letterhead, mail it to the door, done. And so they're used to how that operates. And so I've always said we had to hire some new administrative assistants in Shrewsbury. And when we do the interviews, I said to them, I said, we need to find someone who's well organized and who has great relationship skills, because they are the cog in this wheel. If they fail, the entire thing fails.
But you don't necessarily have a clerical person in each town?
Yes.
Oh, you do?
Yeah.
Okay.
And that would they be still part of the town? Would they be hired by the town or by
Those
Worcester?
individuals are town employees.
Okay.
They're not
Okay.
district employees. So the ones that provide public health services, for in the general sense, are district employees, and the administrative staff and the boards of health still remain in the municipalities working for us.
So would the nurse fall under the district
Yes.
staff? Okay.
Yep.
So you take the technicians, but you leave the administrative staff.
That's how we've done it up until this point, yeah.
Now, how many staff do you have?
We have 18 FTEs.
How many nurses?
2.
In your wheel day, you spoke about evaluation as being one of the pieces. And I wonder, you've been at it now, what, 3 years or so, 4?
Millbury was our pilot, Shrewsbury was our pilot community, which we started in 2010, I believe, so about 3 years now with them. And then as a full district, all 6 of us, this is going on our 2nd year, FY14.
So have you done any formative or summative evaluation with feedback coming back from the communities in terms of the model that you're putting in place in those communities?
Yes, and it's constant quality improvement is what we try to refer as. We just had this conversation. We had the town manager from Holden, Board of Health, town manager from West Boylston, Board of Health members from the district, and we had that same conversation, because I'm not going to lie. I mean, there are still things we're trying to work out. This is new for all of us, and so some of the customer service things, who's doing what, we're still trying to figure out who's doing what on some things. But overall, I would say, and I invite a lot of them to come today, that they're happy with the state mandated inspections are getting done. And we're not just thinking about quantity, we're thinking about quality, that they're getting done in a quality manner. And they're seeing other services that they typically didn't have. And so we have other things on the horizon that we want to try to help be a little more efficient. Kerry Clark has been working with a business organization that is in the process of building a technology tool where all the towns can enter information into one central database. All the town managers and the boards of health members can go to that database and say, gee, my selectman just called me about 15 Main Street. Let me go into this database, pull it up, and see where we are. Was an inspection conducted? Are they in, what process are they in? Are they in housing court yet? So we feel really confident that we'll have that system. As soon as I get the sign off from the CFO, that system will be up and running by January 1st.
But do you have public evaluations now that are available for towns to look at in terms of the data that you say you're data driven? So the data that you've collected thus far, is that available and summarized so that other towns can look at that in terms of your performance in relation to the goals that you've set for yourselves?
Good question. I would say that we're going through the strategic planning session where we had an on-site consultant, and she's going through she's gone to every Board of Health and done a qualitative assessment to try to evaluate where we are. She's also working from the state DPH to do a quantitative assessment on where we are, and it's a dashboard report. We got it last year. I think she told us it's coming out next couple of months. She's going to do a dashboard report of where we are quantitatively with making sure we're getting the inspections done. So that is definitely publicly available. The qualitative one is new to us because we're just going through it right now. So instead of looking at checking off boxes saying, yeah, we did 100 inspections, but what does that really tell you? She's going out to talk to Board of Health members and getting the feedback. And we've heard some great responses. We've heard some things, hey, we really want this stuff fixed. So we can share all those different types of qualitative responses with you.
If we were 5 years out now in terms of where you would be in terms of being the best in New England with health, delivery of health services, what would the model look like? What is your vision of how you're going to evaluate your efficacy in the different communities? What do you see as the model that you will see in place? You must have a vision as to how that's going to be.
Well, you can, if you want to respond to this too, Dr. Hirsch. As far as evaluation, if that's your question.
Well, performance, because all of our towns, obviously, if we move to a model like this, we're concerned that the customer, our consumers, our people in our communities are receiving the services and are getting, we're getting positive feedback as to what's happening. So
Right.
how do you see getting that feedback? What's that loop look like to you?
Right, so in our strategic plan that we're developing, well, actually through the accreditation standards, it requires what you're bringing up. It requires some type of quality improvement measures to be instituted. And so the first question is, how do you get there? And so we will, once the strategic plan is created, we're going to think of ways where we can get feedback. So for example, we talked about this at the department about 2 months ago, just as a first step, engaging our restaurant owners and developing a survey and asking them a series of questions where they can give us feedback as to how they think the services that they're receiving is being provided. From an evaluation performance, looking at ensuring that all of our state mandates are being complete. I mean, we want to make sure that, I mean, that's the core of everything that we do. So that's another evaluation tool. But again, you know, I don't, although they're being complete, I like to take it a step further and say, are they being complete in a quality manner? So it's very easy to pencil whip inspection reports. And so we try to have checks and balances in place and insurance measures in place to hold our people accountable and send them to the proper training to make sure that they're getting that work done. From a community health improvement perspective, we're working with a school in Worcester who is in the process of setting up performance measures for, you know, that very multicolor chart Dr. Hirsch laid out, performance measures where we can look at where are we with lowering BMIs in our schools. Are we still seeing a trend in prescription drug use amongst our youth? Those things right now, we're working with an evaluation team to set those up right now so that we can measure that. So it's a very complex question to answer, and I think we have to take it in chunks because of all the different things that we're doing. Did you want to add anything, Dr. Hirsch?
No, I think you kind of mentioned it before that the medical school has a department of preventive medicine and a department of quantitative health sciences that really is dedicated to this kind of evaluation. For some reason, there hadn't really been a strong link between the Department of Public Health and those two departments in the medical school. So I think we have, through this CHIP process, you know, kind of awoken the sleeping dragon, and they're looking at the kind of data that we could collect as just wonderful opportunity for them to produce reports and eventually publish papers about our efficacy. So I think, again, we are not minded enough in our 18 FTE status to do a lot of this self-evaluation, but I think we have partnered now with some really wonderful groups that will help us with that. So I think there's going to be kind of yearly CHIP progress reports that are going to have those metrics in it that you're looking for. It's just, we haven't quite gotten to even a year yet of the first year. So, but I think it's coming. And I think it's going to be very crystal clear that we're either making progress, or if we find that we're not, that's something that Derek's been very insistent on, we ought to change course. We shouldn't go 7 years down the line in the wrong direction. So if some of our interventions don't seem to be having an impact, we got to tweak them as we go.
Do you have a comment back there?
Do you know the population of the other towns as compared to Grafton? And are they growing like Grafton is?
Population in Holden is approximately 17,000. Leicester's approximately 11,000. Millbury's approximately 13,000. West Boylston's about 7,500, thereabouts. Depends if.
And we're over 18 in Grafton.
Oh, I'm sorry. And Shrewsbury's about, it's over 35. It's probably pushing closer to 38.
Yeah.
So when I'm going to ask a question about inspectional services. So if Grafton still has a lot of streets that don't have municipal sewer or water. So we deal in this town with a lot of wells and septics. So there's 4 steps to a septic inspection. Would the same person go out to that particular home to do all 4 inspections, or would it be different people that go out from the regionalization of this?
Well, what we typically do is have so we have 2 people that are trained to do septic plan reviews, deep hole tests, perk tests. They can do that. Typically, we have a person do the review and follow it through until it's been installed. But I'm not to say that if the person goes on vacation, we wouldn't have the other person go there and complete the project.
Could you put the organization chart back up? I just look like it.
Yeah.
Do it. The technology budget. There we go. Environmental health, the reason why I asked that is because there's some, what kind of relationship do you have with the DEP and the EPA, DEP and the state and the EPA? I know the regional headquarters in Worcester. Is there a relationship that you guys have developed with the EPA, the DEP here in Worcester?
Yeah, I mean, I can speak specifically about my personal relationship with some folks over at DEP, Michelle Del Mar. I don't know how familiar you are with DEP. But
Never met her. No, let me see.
Very close.
Yeah, there are certain people that we probably work with more often than others. Michelle, personally, I've worked a lot with over time. Folks in this group here have, I'm sure, dealt with a lot of other folks over there. There was an email the other day from John Boyer the other day. So we have a, I wouldn't say a great relationship. Who has a great relationship with state agencies? But we have a working relationship with them. Jay, do you have a question?
Yeah, I just want to hear a little bit more. So many times the measure of success in public health is how well you engage and educate the community, how well you reach out, and that they participate. That public health is not a passive endeavor, okay, or a discipline, we'll say. Whether through websites or things of that nature, how well do you get the information? Could you maybe talk a little bit about, you touched upon customer service, and that's very important. We're fortunate to have Nancy. Nancy is our front office person here in the office. So I agree with you 100%. Nancy Connor is the front office person who handles and triages all our calls and things of that nature. But to a developer, to a business owner, you're setting expectations. You say, this is a paradigm shift. You say, well, we're pivoting here, potentially. How do we get that information out? Do you have communications, and whether it's the media, through the school department, things of that nature? Could you just talk a little bit about how well we're communicating with the community, internships, things of that nature?
Well, we have a plan that is coming forth that essentially, almost on a monthly calendar basis, there's always some major focus, whether it's National Child Abuse Prevention Month or National Substance Abuse or Tobacco Smokeout Month, or we have our big Drug Take Back Day on October 26th. And Karen Clark, you should raise your hand. It is now kind of managing a number of those kind of efforts to get that on our city website. We have a Facebook page, we have a Twitter account. We just talked yesterday with the regional group about trying to increase the likelihood that we could maybe send out a blast of text messages for people that have opted to subscribe to it, working with the local newspapers like I think in West Boylston it's the Banner, and there's some of the smaller newspapers that we can get informational pieces out on. And we use the local cable access TV's shows. We have one in Worcester, we've done in Shrewsbury. We have also used a lot of radio spots for getting the word out about mosquito protection, things like that. And we try to be kind of very seasonal and topical, you know.
But those resources would be available to the community. If they were a West Nile or Triple E, then you're speaking to the Grafton community as opposed to the
Absolutely.
Right.
Yeah,
There's a whole team that used to be co-located with DPH. It's now in another office in the city. There's an entire communications and public relations team. It's a staff of 3, and so they've helped us a lot in like pushing information out. So to Dr. Hirsch's point, we just wrote an article in the Banner on behalf of the town of West Boylston. We talked about a lot of the things that happened regionally, and we sent it to the public relations team, and they got it in the Banner, and actually it was well received. I'll pass this book around. This is just kind of an example of just like sound public health messages that we've been developing on a fairly regular basis for the communities. One thing we talked about last night, so one of our problems has been that we spend an exhaustive amount of time developing sound public health messages, and we push it out to the towns, and in some communities it takes off, in other communities it dies. And so we really want to figure out a better way where we don't have to be so much resource intensive, and so how can we get this information out to all the communities in a more efficient manner? And so one of the Board of Health members, it was Thomas Boyson, said, why don't we have our own regional website, and we all can pour into that website, and then create social networking off of that website, where towns, like Shrewsbury has a great technology piece where they have 1,500 people signed up to their Board of Health listserv. And so every time something new comes out, like promoting Prescription Take-Back Day, they hit send, and 1,500 people get that automatically. So trying to mimic, using technology to push information out, whether it's something that's happened seasonally, or there's an event that's happening, or we just want to get information out on a regular basis. We're looking at technology. We talked about it 6 months ago, but I think more so now than ever, we really think that now's the time to do it, because there's a lot of things that are happening, and it can be hard to harness, and some communities doing a better job of pushing the information out than others. Jay, you also asked a question about customer service and this paradigm shift, and there is a little bit of that. So I'll use Shrewsbury as an example. They used to have a full-time health director, a full-time sanitarian, and a part-time food inspector. And that's all gone away since the creation of the Alliance. And so, they had an individual who spent a lot of time in the office waiting for the red phone to ring. And so a great example is these engineers, these construction companies would call him up and say, hey, I'm decommissioning my septic tank. Can you come on down? And he'd get in the car and he'd come on down. Well, we're busy. We're running this like a business to a certain degree. And so what we've now done is we said to these septic installers, we said, you guys know when you're crushing a tank, give us a 48-hour notice. That's not anything unusual to ask, but they would it took them about 6 months to get used to that, because they were used to calling, talking to Bob, and he'd go out there within 20 minutes and watch the decommissioning. And so there is a paradigm shift of really starting to put order into this, and it's not just we're going to do anything as it arises, trying to put some order behind it, put a framework behind it so that we can be efficient.
The other one, you started your talk talking about that you attend the meetings. Each of the Board of Health has their authority, they all have their jurisdiction and issues and all the mandated within the Mass General laws. But didn't you actually deliver a report? I mean, would you be on the agenda, or one of you would be on the agenda?
Yes.
Yeah.
Okay.
Yeah, we've been trying to standardize the agenda so it all looks the same. We haven't got to that level yet, but we're getting there. There's always depending on the town, there's always something for us to report. So in some towns it says health agents report, and other towns it says health director's report, sometimes it says regionalization update. But there's always something on the agenda so we can go there. So typically we have the inspector go to talk about what's happening in environmental health, the inspections, what's happening in restaurants, and then an administrator go to talk about some of the things that are happening on a policy level that the board should consider. So you always, I would say 95% of the time there's always been 2 people at a Board of Health meeting to represent environmental health and policy.
Another question, and you have a fairly good array of diverse public partners, coalition partners. But we in our community, we also have a good number, I think, of Tufts University. You open that to new, should there be an opportunity for new partnerships, the veterinary school and other, even just businesses who want to get involved.
So we didn't really go into it, Jay, but one of the things, for example, on the university level is we're working to try to establish a center for public health learning at the Department of Public Health that would give all universities, vocational schools, the opportunity to be in an organized faculty coordinated program where if they had to do, the big hallmark name now is capstone, everyone has to do capstone projects or service learning projects. And we feel that the DPH is a great place for them to do that. They would get some expertise as far as supervision and mentoring, but they may actually be able to advance projects that we actually need to have accomplished as part of our community health improvement. So it's a win-win if it happens, and I think we're pretty optimistic that it's going to move forward, and that will give universities like Tufts Veterinary or where the local high school, if there's like a health tract for those kind of students, we welcome them. We want that kind of help.
And that's, if I can mark that's this block right here. This is the Center for Public Health Practice, where we'll have multiple feeder universities and their faculty taking a piece of public health and implementing it on our behalf. It could be anything from research or policy development or inspection, like Dr. Hirsch pointed out. So there's actually a lot of momentum with 2 universities right now that, again, I would envision probably sometime in early spring that we'll have MOU signed with those universities to formalize that Center for Public Health Practice. So,
from a fee structure standpoint, would you say that it's based more on a fixed basis with a set level of services up to a certain point that you deliver, or would you say it's more variable in pay per drink with some, because some towns have bigger needs than others? For example, obviously Shrewsbury has Route 9, we don't. So we don't have the 20 million restaurants in a short period distance of time. So as far as consumption, we're going to use differently than, say, a town like Shrewsbury would, which has a lot different type of setup.
Right, you're absolutely right, but at the same time, your consumption, you may be heavily more somewhere else. I thought somebody mentioned that 40% of the town is still septic. So unlike Shrewsbury, which is they have a lot of public sewer in town, the heavy consumption in Shrewsbury will be restaurants, but in Grafton it's going to be septic. So right now, the formula that we've been using is a 3-tier formula where 0.5 FTE, a $1 per capita, and then looking at the environmental health work and using that as a basis. And like I said, in all the communities that we've worked with, it was either at what they're already paying or it was less than what they were paying.
Do you have an average ratio of what I mean, you gave a reference of 90 down to 60 as an example. Do you have an average percentage that you've typically found that you've saved towns that have gotten involved?
An average, I mean, I can tell you what Leicester's paying right now. They're paying $55,000. Holden's paying about $67,000, and Shrewsbury consumption's paying about $100,000.
West Boylston, just make you take them all off. Just to make you tell them all. What's West Boylston?
West Boylston, I think, is $31,500. Again,
you have to do the comparison of what their budget was before joining, so it's difficult. Even the towns that aren't in it, when I did the kind of anecdotal survey I did, you have plumbing inspectors in some of these boards of health, which we certainly don't have it in our board of health, plumbing inspectors in the building inspectors department, so it's like those things.
Looking at the
overall
pull
those pieces out to understand what those community true costs were before they joined and what they are now.
Right. Like I could speak to some of the costs for some of the other towns, like West Boylston, when they started, their cost was, I mean, they had a revolving account, they had a $10,000 appropriation from town meeting, but they were spending about $28,000 a year.
The other important piece is this is we're at the baseline service level in Grafton. We can do so much better, and as much as we think we want to save money, I mean, I think having a healthier community is priceless. But we have to operate within that box. But if we can get the higher level of public health, I saw the small sliver up there on the second wheel, not the first one. about school and healthy lunches. I don't, it was a small sliver, and I know this is very detail oriented, but I have no idea what you guys do, but I would like to follow that thread someday, because I'd like to know what, because we contract out school lunches now, and a lot of it, from what I hear, just kind of goes to waste, because it's horrible food that's mandated. The kids aren't eating it, so I mean, what can we do to make that more consumable? Because ultimately, that goes to the landfill, that I gotta pay to burn that stuff in Millbury.
You're paying
If
for
I get them
lunch
to eat
begin
more,
with.
I'll pay less. So there's so many different threads.
Oh, yeah, and that's the thing, there are so many different things that you can consider doing, and in my mind, some of it's just getting started. So Karen is leading a youth survey throughout all the regions. So just so you all know, youth survey, if you're not familiar with it, the last time we did it cost about $50,000. It's probably going to be about $35,000, $40,000 this year, and we're paying for it. So we go and seek out those grants, and we're doing a youth survey in all 6 communities, and we're going to get a better sense working with those school districts on what's going on with their youth, like some of the good behaviors, some of the bad behaviors, and then we'll be able to be very smart about identifying the priorities in those schools or in those communities for their youth. So healthy eating and active living is certainly one of them. And the other thing too is like, yeah, I think public health has been forgotten to a certain degree, and so when you look at it from a planning perspective and how you're designing communities, public health has a large voice in that. And I'll just talk about the city of Worcester alone. We are always being called by the planning department saying, hey, we got a new development going in, what do you guys think? What are your thoughts on this? And so it's all about designing communities a little bit healthy too. Complete streets, connecting sidewalks to neighborhoods, and a lot of that stuff, because of suburban sprawl, it was forgotten about. I mean, I can guarantee you, because I can do it in Worcester, I can drive through neighborhoods with the sidewalks just drop off. Well, there's no sidewalks in some neighborhoods, like the neighborhood I live in. And so it's not just, it's a lot about policy development too, not making, obviously we want the kids to eat better, but if you tell them to be more physically active and they go to the neighborhood, they can't walk in their neighborhood. That's difficult.
Yeah, walkable communities are big.
Yeah, and it's a big movement now.
Yeah.
I guess like Tim is saying, I don't know if anyone could disagree with all that's on the board there. Obviously, there's a lot of benefits to do a lot that is not being done now towards having a more healthy community. But you said something else, so I have a kind of a two-part question or response here. When you talked about, we'd like to run it more as a business and we have to tell our contractors they have to schedule 48 hours in advance. I think, and I only speak for myself in the town of Grafton, but I think we pride ourselves when we try to keep it simple. And I think there's something to be said. I don't think we have people sitting by the red phone waiting for it to ring to do something. But I also think that there's something very beneficial to be able to have Nancy have someone there who can go out and be there so that our contractors, because we have 40% of our people, and as the bumper sticker says, such and such happens, and we're not always good about programming that every 2 years do the cleaning and everything. So sometimes we have a lot of things that are unexpected. But I think the response that I think our community wants, and I'm speaking for myself, is that kind of immediacy that's available when you have a person on site. So I guess my question is twofold. So if somewhere like Grafton wanted to have that kind of a feature, as I understand it, you're going to customize each of the agreements around what the towns want to do. I wonder, do you have any thought of having like associate members for towns, or memberships that would buy into certain things but not others? In other words, if we wanted to participate and have the resources of the research and all of the domains and have that availability to us, but at the same time we want to maintain our own inspectional services or whatever we decide it is that option available, or is it an all or nothing kind of approach?
Oh, to be honest with you, it has been an all or nothing at this point, because it's so because this work is built upon our grants.
So is it an all or nothing?
I mean, I'd like to say that if it's a deal breaker, then we should have a conversation. But if you ask my preference, we would prefer an all or nothing, because that's how the other towns are doing it. And one of our major goals is to standardize, you know, how we're gonna deliver public health services. And so if we have communities, you know, just, well, I only want, you know, it becomes like a la carte menu. Well, I only want this one here, and you know, I'll give you $10,000 and you can take care of this stuff. Then from a person who has to deal with the money, I'm like, well, how am I going to make that work? Because that's going to require FTEs, and $10,000 doesn't get me nothing. You know what I mean? So it's very, from a long-term
What I see though you're
standpoint-
doing, and I think it's very noteworthy, and you do have considerable grant funding to help you do it, but it looks to me like, you know, you're in the growing period, and that you're doing everything that you need to do, the needs assessment, the setting the goals, the going through the strategic planning process. But it would seem to me, with the size of your core group right now, it probably would be to your benefit to have that group not get too much larger in terms of growth, so that you have the ability to manage that, and then at the same time work with satellite groups outside of that group that perhaps can plug in a future way, so that there may be communities like Grafton or Upton or other places that might want to be more an associate member, and we're not probably going to be the major contributors, but you do have a lot of grant funds and other things to help you right now. But over time, we may build our capacity into wanting to go that way, if you know what I'm saying.
Yeah, no, I absolutely, you know, some communities would rather take small steps and test the waters and make a determination from there. But I would say that we're not out there beating the bushes asking towns to sign on. You know, to be honest with you, we're being very strategic on who we're having conversations with, because we recognize that we don't. There have been some communities like that are down 395 that have asked us to come engage them, and geographically it doesn't make sense, the dollars don't make sense, and so, you know, we're not just signing agreements because other communities are doing it. So we're being very strategic, and you know, towns that are contiguous to Worcester or right outside of Worcester, the towns that we think make the most appropriate sense.
Thank you.
Can I did, on PO, one up back? I have two, but.
Just one more, and this will be my last. We're drifting a little bit into the economics of this, and I understand that obviously each of the selectmen and the town administrator has to work with that. Is there an option for even a 6-month trial basis to say, listen, we don't sign a full agreement, you know, we're a full year, but we have some sort of to test run this for, see what this feels like for us, to see what that would be. And maybe you don't have an answer for that, and I understand, maybe you have to go back and look at that, but might that be an option where we said, hey, listen, I don't know if you're aware, but our health agent left, so we're on a contract basis right now, and so that, might there be an option where we say, listen, let's see what this will look like to include for I just throw out there, a 6-month basis. Might that be something? Is that, would you at least even consider something like that?
Yeah, I mean, we definitely would want to do that, because, you know, I personally think a town like Grafton makes a lot of sense, given the communities that are already involved in, and you know, to test drive this for 6 months and see how it works out. It's certainly something that is doable. You know, I would, again, you know, for long range planning, you know, it's something that we like to build into future budgets as to how to make this work, because when you do something on a temporary basis, you're not getting the full impact that you would if you were truly, if you were in. But yeah, I mean, there's definitely, given the circumstances in town, I think that's something that's worth exploring.
I think the difference is, you stated, is that obviously some communities do more of a shared services where they're trading services,
Okay.
but that's not your model. Your model is you buy the entree, you get the salad free. So I mean, you can't give away the salad if you don't buy an entree. If you're going in there for the 99-cent menu, that's just not going to happen.
I rather have dessert.
That's right.
That's right.
Yeah, and you know something, in the state there are a few other shared services models that are out there. This one, and there's one out in the Berkshires, I believe, is the only two that have this like comprehensive, centralized model. Because it just made a lot of sense for the communities that wanted to participate, that why don't we just do it this way, have one administration manage it for the entire region versus multiple. So did you have a few?
Yeah, just, other community, you had 6 other communities about Worcester, so 5. did any of them do kind of to ask staff to figure out what their service levels are? We think we do a great job in all of the things that we provide in terms of public safety, permitting, but maybe it would help us get a better feel, like those interns you talked about, to do some program analysis in terms of service delivery and that model, and kind of do that evaluation externally from the operations and have it kind of impartial. Say, this is what you do now, and this is how you rate, if you will, and this is what it could look like when we see the wheels, and what you could get for services. So it's not personally driven. Somebody else is kind of looking at that level. And I don't really know how to ask that or say it, but I just said it the way I did. But there's been, when people come to me about Worcester, they can't even do their own restaurant inspections. I don't know why they think that. I don't know if it's true, but since I hear it all the time, I'm just going to say it so we can just say it and get it out there. And I don't know if it's staff constraints. I don't know if it's the same group doing the work that you're doing here with the other communities, but since I hear it, I just figured we might as well just put it on the table.
So that's a good question. So I'll answer the last one first. This is the Department of Public Health in the City of Worcester. The Department of Public Health in the City of Worcester does not do inspections in the City of Worcester. We only do inspections in the region. That is it. The Department of Inspectional Services does the inspections for the City of Worcester. So,
is it a different department?
Completely different department. We have no oversight. Dr. Hirsch and I have no oversight of that department. It was a part of the 2008 reorganization where the city manager wanted to centralize inspectional type of staff and wanted public health to focus on community health improvement, looking at high burdens of disease, policy, nursing services, clinical services, things of that nature. So in 2008, there was a separation of that work. Now, because of regionalization, like I talked about in my first comments, that environmental health is a major component, statement in inspection is a major component of the work in the region, we had to take that on. And we can take that on because a lot of us grew up in that system to begin with, so we understand what that means. So that's this column here represents the Department of Public Health's contribution to environmental health in the region. So we have nothing to do with whatever Worcester inspections happen. Now, if there's an outbreak, they call us up because we have people like staff as epidemiologists, we have nurses that provide them advice and information, but we don't, but we're two separate departments.
But yet you do restaurant inspections in other communities?
All the communities
except for Worcester?
Yeah.
Okay.
Yeah.
And how many are there? How many inspections do you have?
In the
food inspection.
And the Worcester DPH or inspectional services? We have 4 inspectors.
Okay, 4 inspectors.
For 5 towns.
And are you meeting mandated requirements?
For me and every one of them. And to Selectman's point, we have a dashboard that this third-party evaluator gives us on an annual basis that demonstrates our commitment to meeting those state mandates.
Now, 24/7 or immediate complaints that come into the Board of Health locally, you would expect those kind of complaints to be handled by the local Board of Health?
No, we do them.
Okay, so what's your response time? What would your response time be in Grafton?
After hours or during the day?
After hours.
After hours in Grafton, response time, let's see, I'm trying to think, who's the closest to Grafton? I would say response time would be probably 30 minutes.
What about on Christmas morning, for instance?
Yeah, I mean, it really has to do with proximity to the town.
Oh, well, the intermunicipal agreement would spell that out, wouldn't it?
Right. Well, yeah, it requires 24/7 coverage, and we do that now.
So your expectation would be 30 minutes?
Our response time at the earliest would be 30 minutes, yeah. It would take about 30 minutes to get to Grafton. I'm thinking, because I'm just thinking of proximity of after hours, people where they're located. We've got some people that live in Worcester. We have some people that live in Leicester. Some people that live in Webster, Oxford area.
So it depends on who would be responsible. Do you have somebody that is responsible for, in other words, each person, all people are 24/7 response, or do you shift that response?
We shift that response.
Okay, so one night it could be somebody who lives in Leicester.
That's right.
Or one night it could be somebody who lives in Where?
Julie live, Oxford.
Okay, so it would depend on the night of the response requirement.
Right, and it also depends on the event too. So if there's a dwelling fire that requires an immediate response and the person on call that night lives in Oxford, that person needs to know that I can't get there for an hour and a half because I got my 2 kids. Can somebody else get there because this is an immediate situation. If it's a
So you have a phone tree if you need, you know what I mean, you gotta make the phone call.
yeah, we have a system, a pager system where we have people on rotation.
Okay.
Because the problem we had early on was we had all the people that were assigned to their towns, and I just feel bad for one person who got called out like 3 times in a 4-day period, and it was just too much. So we said, you know something, we'll have a rotation, 24/7 rotation, where one individual will be assigned to provide that coverage, and then they're off for 7 weeks. And that's how we've been working it.
And then depending on what, if you were to take on other communities and potentially take on some of their staff, depending on what it is and where it is.
Right, that's
You
right.
might end up with people closer to
Closer
you
by.
after all.
Right, right, and the original Leicester inspector actually lived in Leicester, so it was really easy for that. And I would say the town of Millbury is a 3-member elected board, and they are very involved in the after-hours stuff. And in fact, they've said to us, they're very gracious, they said, you guys don't even worry about that stuff. If we can't get there, then we'll call you guys. So they've been good to us.
Do you get a discount for that? Because it's what you and
I can just tell you, I came in, I was a food inspector in the 80s, and I lived in Worcester, and was involved in Worcester. A 30-minute response time is a wonderful response time. I lived in Worcester, was called to it, so that wouldn't concern me in the least. I mean, you could have an inspector that lived here in Grafton and still get a 30-minute response time. That's very reasonable.
Yeah, and it depends on the proximity of the person who's driving there. I mean, it took us 20 minutes from Mead Street in Worcester to get to this facility, so it's all about drive time.
Does the agreement that you structure with towns have specific SLAs with perform and penalty clauses if you don't meet certain standards?
It has a 30-day opt-out clause. So if you are unhappy with your service, you have to give the city of Worcester 30 days notice and you can opt out.
Is there any clause in there relative to accessibility? If you, like, you had a multitude of calls, you're paying people overtime, could there be an assessment back to those communities for that added cost?
No, we end up, even now, to a certain degree, the city has been bearing the burden of other miscellaneous costs like mileage reimbursement, technology use, and we're fortunate because we've been having the grant. I mean, the district incentive grant provides up to $75,000 a year, and we've been using those dollars to subsidize some of the other costs. But we haven't done that. We don't have an overtime budget, so we use comp time and flex time to compensate those individuals have to go in after hours.
Which actually, the whole permitting departments are reading now relative to permitting software. So I know you talked a little bit about the website and funneling information in. I certainly don't want to buy a module for a permitting thing for a Board of Health. If you guys either have one or are developing one or plan to get
But
one.
the software we're talking was really about personnel management and complaint management. So we can manage our people who are out in the field, 1, and monitor them, and 2, from an administrative standpoint, all of us, you included, Select Board and others, can look at what's going on in their community relative to complaints. Because we all know when an elected official calls, you want to be able to get back to them and tell them this is what's actually going on. And so it's a little more difficult to manage it when you have 5 communities. So this is a system set up in a cloud where anyone can log on and say, yeah, this is what happened at 15 Main Street. It'll be in district court next week. We'll get back to you and let you know what the judge says. So, but that's not the permitting software, which, what's Worcester? Worcester's view permit. Shrewsbury is like some Hawkeye system, which I heard bad things about. So I would just encourage you to really look around.
Go live next
Yeah,
week.
permit view is really the Cadillac, and it's obviously
Right.
where my eyes are set, but I don't know if I can afford it.
Yeah, it's expensive, but I heard that it's definitely, worth the
Right.
money.
Yeah.
Definitely worth the money.
I think 3 questions ago was my last question, but I'm going to ask you, policy. The Board of Health says we want to look at body art, we want to look at tobacco, we want to, you have those kind of, the different policies that we come in and take a look at and say, we may want, we may not want to, but something that we could review.
Yeah, I mean, oftentimes Board of Health members, there's an issue, that's happening in the community. Like there's actually right now one going on in a couple communities around chickens and other loose animals.
It is a chicken.
And yeah, and so boards want to ask us to look at regulations and present them regulations. And so we'll do that. The other thing, good thing right now, we're really lucky that because of the grant, we have Copeland and Page on retainer. So if we have to just circle back to an attorney, we circle back to them. Well, again, because of the grant.
So talk about marijuana.
What do you want to talk about?
Well, you got the distribution, you got the cultivation. Would you have policies around that? And is there any?
We have been, I actually just presented before the Economic Development Committee in Leicester 2 weeks ago, and been working in the city and Shrewsbury all on marijuana. So we've been recommending that boards consider developing some local regulation so that you don't have to, the state regulations don't require a local adoption of regulations, but allow, if they choose to do that. And we think it's a good practice to just have a local regulations. It could be focused on public health, it could be focused on public safety, but it allows you to get in there, to put eyes on the facility so that you do know what's going on in your community. So we would recommend that you do something.
Would it be the authority of the Board of Health to set those regs, or would it have to be a bylaw at town meeting? Because they have tons of authority in terms of regs.
Right, so the boards of health, as you know, can do that at any public hearing, and they can hold a public hearing at any time, unlike town meeting. So it really depends on which way the community wants to go. If you want to have a regulation that's written heavily on public safety and surveillance and that aspect, you really should go to a town meeting. If you want to have a regulation that's heavily built on public health and looking at edible food products and things of that nature, then go to your Board of Health. So you really kind of want to look at how you want to structure your regulation.
That's all.
That's what we do. So they pay us to do.
Very good, very good.
Hey, Tom?
Thank you.
We're hoping also that some of the monies that we've been accruing, we're going to be able to do a little bit better with technology. I bet you any one of you that have teenage kids could probably wire their friends together better than some of our departments of public health have been. So I mean, some of the meetings that we have are great to have face-to-face, but some of the day-to-day stuff, it would be great to just, do FaceTime or whatever kind of programming we do to just kind of get an eye on the other people, but don't make them kind of come to a central place. So we talked about that yesterday at our regional meeting. I think we're going to try to work on some of those kind of technologies.
Thank you.
Thank you for coming. Appreciate it. Thanks, guys.